Welcome to On the Beat, the pulse of gynecologic oncology, brought to you by the Regroupement des Gynécologues Oncologues du Québec, RGOQ. Before we begin, a brief disclaimer. This podcast is supported by an unrestricted educational grant from AstraZeneca. The content, expert selection, and topics discussed are fully independent, and the opinions expressed are those of our experts, free from any influence by AstraZeneca. This discussion is intended solely for healthcare professionals and is for informational purposes only. It is not medical advice and should not be taken out of context. By listening, you agree that this content is not intended for patients or the general public. For personalized medical advice, please consult a qualified healthcare provider. Now, let's get started and explore the pulse of gynecologic oncology.
I have the pleasure of being with Dr. Stephanie Lheureux, who is a very well-known, very published medical oncologist at Princess Margaret Cancer Center. And today we'll be shedding light on her expertise on what's coming, mostly in platinum-sensitive ovarian cancer and ADCs. So we're really excited. Thank you so much, Dr. Lheureux, for being here today.
Thank you so much for having me. It's a real pleasure to have this discussion with you today.
So I think the hot topic right now is ADCs, and I think we can't help but talk about start with a bit of platinum resistant in the platinum resistant setting where we have mirvetuximab, and now we have it in the context of a trial. But how do you foresee once it's approved by Health Canada, how do you foresee that it's going to be integrated in clinical care in the platinum resistant setting?
Yeah, no, I think it's an important update for patients with platinum-resistant ovarian cancer because unfortunately in this setting, we don't have a lot of trials showing a benefit in overall survival. So I think it's as a significant milestone for our patient. And that is based on the MIRASOL study, which was a phase 3 randomized trial assessing the mirvetuximab, which is an antibody-drug conjugate, versus our standard of care chemotherapy. As part of the standard of chemotherapy choice was single-agent chemo. As part of this trial was either with Taxol, Caelyx, or topotecan. And what is important as part of this trial was the fact that patients were selected. And this is because the mechanism of action of the mirvetuximab, which is a ADC targeting the folate receptor, and based on the prior study that was conducted, it's important to select the patient based on the expression of the folate receptor. So this trial was selecting patients with platinum-resistant disease with a folate receptor alpha, which were detected by IHC with a specific definition of at least 75% of viable tumor cell positive with a PS2 intensity. So it's a very high expression of the folate receptor in the terms of the expression, but also the intensity of the expression of the folate receptor. And it was targeting patients with high-grade serous ovarian cancer, and it's important to note that the platinum refractory were excluded, and they limit the number of prior lines to 1 to 3. And in terms of prior treatment, prior BEV and prior PARP inhibitor were allowed. And this trial actually showed there is a benefit of mirvetuximab compared to the investigator choice chemotherapy in terms of the progression-free survival, but also in terms of the overall survival. So I think that will be integrated in our practice if it's approved and covered by Health Canada.
Mm-hmm. And do you think, should we take into consideration like the folate receptor testing? How do you think that we'll be able to do that? Do you think each center's pathology labs will be able to take that on, or do you think it should be centralized?
So I think it's an important question, and I think if we look back at how we incorporated, for example, the BRCA testing initially for high-grade serous ovarian cancer was a learning step, and now is actually part in our current standard of care. So I think it will be the same. So I think initially for the folate receptor, you need to have a centralized because you need to ensure that the test is appropriate and consistent. So probably initially will be centralized, and then after, depending on the implementation, hopefully more sites will be able to do it. Mm-hmm. But initially will probably be centralized given the fact that it's an expression and intensity in terms of the selection of the patient.
And in terms of the management of the new side effects, mostly ocular side effects, what tips do you have for people in managing that?
Yeah, so I think it's interesting because it's new toxicities that we were not used to see with standard chemotherapy. So I think with standard chemotherapy, I think we are used to manage the heme toxicity, the GI toxicity, which we still see with this type of ADC. But in addition, with mevatuximab, we have some specific ocular toxicity, which include blurred vision, keratinopathy, or dry eye. So I think it's very important to have the ophthalmological assessment initially before we start, and ensuring that we ask the patient regularly about these specific symptoms, because they may not report, we may not think about it initially. So it's very important actually to have patient education and the healthcare team education about the specific toxicity. And there's also some preventive measures that need to be done. So there's some specific Collier that need to be given to the patient, and they need to apply that several times a day to ensure that we prevent this kind of toxicity. And if, despite this preventive measure, the patient still reports some eye toxicity, it's very important actually to hold the treatment, because normally the toxicity will resolve by holding treatment. And depending on the evolution, either we can resume or dose reduce. But it's something that it's a new toxicity that we were not used to see. So education is important, and prevention, and really dose adjustment as needed depending on the symptoms.
Oh, that's really great. And, I think some centers that have these in clinical trials are starting to get used to the management of symptoms. That's great.
And I think
Uh,
it's true, like you need to have, if this kind of symptoms appear, it's important to be able to refer to an ophthalmologist to assess the symptoms in a timely fashion, because sometimes additional treatment need to be given depending on the eye exam. So I think it's important to ensure that you have someone that you can refer your patient to if there's some specific symptoms that are reported.
Mhm. And so we have experience with the 424 trial right now. And so in that one, they mandate that like very regular ophthalmologic assessment. So I wonder if, once we get it into routine practice, maybe a baseline one and one like every so often, just to make sure that the patients are okay. So now moving more into the platinum sensitive setting. So we just wanted to have a informal conversation about ADCs. So first of all, if you could just tell us what is an ADC itself?
Yeah, so I think ADC it's a very new class of drug that the ADC it's characterized by I would say three main components. So I think it's important to know that, because it really then the side effect, the activity will depend on the specific characteristics. So I think it's really important when you describe ADC to at least describe the three components. So one is definitely the antibody, which targets specific antigen. So that is a very important component. The second component is the payload. And the payload can be either a kind of an antitubulin payload, for example, mevatuximab, but you have now a new payload with a topo-1 isomerase inhibitor, which are currently in development as well. And then the third component as part of the ADCs that is important is the linker. And the linker is important because it gives potentially the stability of the payload while the ADC is in circulation. So the three components are very important. This characteristic will lead to a specific profile of the ADC. And then something also that can be described as well with the ADC is the DAR, so the drug ratio, because you have the payload, but then you may have a different number of payload to the linker. So that is also very important. You have some DAR going from 4 to 8, and that also gives a specific characteristic to the ADC. And that is also where the technology evolved, because initially the DAR were more 4, and now we can have some DAR 8 because of the advancement of the technology, where the ADC is more stable than it was before. And I think with evolution, we may think about new technology of ADC with combination as well. So I think we need to see ADC as a really new drug delivery tool. So for now, as we know in ADC, the payload is mainly still cytotoxic chemotherapy. But that may evolve over time. And what is interesting is, for example, we have a lot of ADC now with the topoisomerase 1 inhibitor, and seems having some interesting preclinical and clinical activity in early trial. And it's something that we didn't see before with the topotecan, for example. So really show that the improving the drug delivery and the drug technology is important. So I think it's a very interesting new class that we will see more and more under clinical trial.
And so are there any examples of specific antibody drug conjugates that we should be looking out for?
Yeah, so there's different, there's actually, like, it's what is impressive is actually there are more than 40 ADC currently in development. So it's a little bit overwhelming. So I think these few ADC that are currently in a large phase 3 trial. So there's still some ADC targeting the folate receptor alpha. But there's other ADC with targeting the HER2, and we have seen a recent presentation with the TDXD, for example, in gynecological cancer, showing interesting activity targeting HER2. We have also some ADC targeting the TROP2 that are also in phase 3 clinical trial. And we have also some ADC targeting the CDH6 that is also in phase 2, phase 3 trial. And we also have some drug targeting the B7H4 target. So as you can see, there's a lot of ADC in development, and it's hard to sometimes, have the full portfolio, but really showing that there's a lot of activity in this area.
And for sure, I think it's going to be difficult. Like, for example, in platinum sensitive setting, our center, if we can, we tend to favor possibly doing surgery. We even go further and do high PEC based on the chipboard trial. So I think, and we're living that in endometrial cancer right now. So with all the immunotherapy, where does surgery fit in? Can we do surgery? And so I think that's going to come this shift also to ovarian cancer. So really selecting, if we believe that the ADCs are stronger, will there be a role for surgery? And also then adding the PARP inhibitors on top of that, how do we see that all juggle in together?
Yeah, no, I think it's an exciting time because we have more options than we had in the past, but now it's how to select the right drug at the right time and the right approach for patients. So that I think that would be something that we will need as clinicians to try to answer this type of question. If we, for example, look at how ADC are developed in the platinum sensitive, if we take, for example, the platinum sensitive, we currently have the trial, which is the Lheureux trial, trying to bring bevacizumab a little bit earlier than the platinum resistant. And the strategy was that after platinum-based chemotherapy, patients were randomized to having potentially the bevacizumab as a maintenance treatment. So that is a new area that is currently under assessment, the maintenance strategy in the platinum sensitivity with ADC. Maybe another avenue for ADC is, can we replace our standard, cytotoxic chemotherapy, or can we replace eventually the definition that we have of a rechange of a platinum-based chemo with an ADC? But all of that is currently under assessment, so that will shift a little bit of our current. All of that is currently under clinical trial, and we need to wait the result before changing. But you're right, the platinum sensitivity, you also have the question of surgery that always need to be considered for the recurrent platinum sensitive. Is debulkable again? So I think it's still a good question to assess for our patient before going with our standard systemic treatment.
Mhm. And, I think, like you said, like targeting the right patient, I think we're sort of figuring that out in endometrial cancer with molecular markers. And I think in ovary, with the predictors we can think of is BRCA, of course, HRD, and then you and I published together about the Kellam score. And so I think that's something that we're starting to use in clinical practice, especially having, talked personally with Dr. Yu. I think these are kind of helping us now make decisions versus surgery, no surgery. And I think targeting these patients with which now antibody drug conjugate do we select, not only for their specific markers that are the targets, but also these kind of predictors. So as you said, it is really exciting, and just kind of to see what's going to be the best thing for the patient. And I think overall what we want is obviously to increase survival, and less side effects. So speaking about side effects, any specific ones other than the ocular toxicities people should be looking out for?
Yeah, and before going to the toxicity, hearing you talking, I was thinking we still have a lot of unanswered question with ADC because we like to select our patient based on biomarker, and in ADC area is still a question that we need to answer because if you look at the different ADC currently in development, as we saw with the mirvetuximab, the selection of the patient based on the folate receptor was very important. But some current ADC are developed without this biomarker selection, despite there is a target and the antibody linked with this target. But some ADC actually are not selecting patients based on the target expression. And that is interesting to see. And why? It's because maybe you saw, all the story about the HER2 in breast cancer. So it's also another characteristic of ADC that is being explored is the off-target. Because when you give the ADC, there's a potential off-target that actually can be seen and have effect on the cells that are not expressing the antibody. So I think there's still a lot of research that is required to actually define and select the patient for the ADC. And some question as well in terms of sequence of the treatment. Because, depending on the payload and if patient were previously exposed to an ADC, for example, if mirvetuximab coming in practice, how potentially you sequence ADC. So I think this is still will be a very interesting area of research. And regarding the toxicity, each ADC will have different toxicity profile based on the specific characteristic. And in terms of the toxicity, you have off and on target toxicity, you have off and on site toxicity. So it's a little bit different than what we were currently used. And we often have some similarity, which are the hematological toxicity, because for now the payload is still a cytotoxic agent. We will have often the GI toxicity as well, the fatigue that remain quite common between the ADC. But then after the specificity, some specificity, for example, that we discussed about the eye toxicity for some of the ADC, we may have some specific toxicity regarding the pneumonitis. And we saw that, for example, with the TDXD, where you have, some patients that develop pneumonitis. So that is something that is very important as well to be aware, to monitor with baseline CT scan and then CT scan on a regular basis to assess the lung, but also assessing specific question with dyspnea, cough, because pneumonitis is something that can be seen with specific ADC. And for patients with this so matter is the alopecia, but the alopecia rate also vary for ADC. So you have some common toxicity, but some after you have some variation depending on the type of ADC. So it's why it's very important to know the characteristic of the ADC and have some education around it.
Mm-hmm. That's really great. So I mean, I think we did a good overview of the ADCs and what's coming. Do you have any final thoughts of anything new in the platinum sensitive setting?
Yeah, so I think in terms of ADC, I think what would be very interesting is to see if ADC may eventually replace some of our standard chemotherapy. And potentially, we have now a lot of ADC developed as a single agent, but what is coming is probably the combination strategy. So I think because the idea of increasing your therapeutic index by ADC is the hope of ADC. By improving your drug delivery, you're improving your drug therapeutic index, and maybe will be easier to combine. So I think what is coming as well is eventually to combination treatment, and maybe, switch a little bit our initial thought about platinum sensitivity, why is a re-challenge of the platinum. So maybe over time that will evolve. And as you say completely rightly, is our treatment may change in the platinum sensitive, and we will have to consider different options at that time, including surgery. So I think it's an exciting time for our patient, and selection of the patient, I think, would be very important, and still a lot of work to be done in this setting.
And I think like something more philosophical, I was reading like what even more basic, like what does platinum sensitive really mean? So in our learning, it's 6 months, but some people say it could be 3 months, and it's not necessarily time, it's more like the biological behavior. So I think, just like in the surgical world, like little words like debulking or cytoreduction and completeness, like all these words have kind of changed. And I think how we classify patients, like we're seeing in endometrial cancer, is more molecular, then maybe the term platinum sensitivity is going to start changing as well.
And you're right, because GCIG actually, we have this 6 months Terricol cutoff, which is still used for most of the clinical trial. But GCIG last statement says that, eventually, a 3 months cutoff in practice may be, used. So I think is that it's something that we use in practice, but doesn't necessarily correlate with any biological rationale. So I think it's something that will further evolve, I think, over time. And with all this new drug and strategy coming, I think that will change this specific paradigm.
For sure. Well, thank you so much. And we're so grateful and happy to have you here with the RGOQ. And we look forward to future collaborations in these trials and in the podcast as well.
Would be happy to. Thank you so much for having me.
Thank you for joining us on the Beat, the Pulse of Gynecologic Oncology. We hope today's episode offered valuable insights. For more content and to stay informed, visit us at rgoq.ca. Until next time, stay informed, stay connected, and continue advancing the care of women with gynecologic cancers.